Okay, so in this lecture, we're going to cover neurological disorders. In this picture, I've depicted two neurons, the neuron here as well as a neuron here. And in between those neurons, there's a synaptic cleft in which, following an action potential of the first neuron, there's release of neurotransmitters into the synaptic cleft that ultimately bind to receptors in the receiving neuron, results in depolarization of that neuron and propagation of that action potential or signal down to its next target, whether that be a neuron or a motor neuromuscular junction resulting in contraction. So the first thing we're going to discuss is a background of the nervous system. And we're going to discuss Guillain-Barré syndrome and then myasthenia gravis. And in both of these disease pathophysiologies, we're going to discuss the pathogenesis as well as the prognosis or treatment. Now, there are a lot of neurological disorders and pathophysiological conditions that affect neurological function, but these will be the two predominant disorders that we'll discuss in this lecture. So starting with the brain, action potentials that are transported down the spinal cord interface with the ganglion, in which there's neurotransmitter release into synaptic cleft, resulting in depolarization or initiation of an action potential of peripheral nerves. We'll discuss the physiology of these nerves in the next subsequent slides. But ultimately, when this signal is propagated down this peripheral nerve, it interfaces with a neuromuscular junction in which there's neurotransmitter release, oftentimes acetylcholine, into what would be called a neuromuscular junction. And then that ultimately leads to muscle contraction. Now, this system can also work in reverse, such that sensory receptors in your musculature can become activated. And when they're activated, there is initiation or transport of an action potential down a peripheral nerve back to the ganglion at the spinal cord. And that junction release, again, neurotransmitter release occurs, resulting in depolarization of the spinal cord nerve. And that ultimately is relayed back to the brain and is involved in perception of the stimuli that initiated that action potential in the first place. Now, if we take a look at neuron physiology, what you observe is a cell soma that contains a nucleus. So this cell soma is considered the body of the neuron, the body of the cell itself. Now, it receives signals from dendrites, and also in this case, in this blue right here, you see what would be called presynaptic neurons, and those would be neurons that are releasing neurotransmitters into synaptic cleft for this nerve to respond to. Now, what happens is that when neurotransmitter is released and stimulates this neuron, that neuron begins to depolarize. And if the stimuli coming from this presynaptic nerve is strong enough to result in enough depolarization of the cell to meet a threshold action potential or threshold membrane potential, then an action potential is initiated in which there's complete depolarization of this neuron following to a repolarization phase. And ultimately, this neuron membrane potential returns to baseline. And so when we talk about this membrane potential, what I'm talking about is the relative distribution of positive relative to negative charges within the outside, exterior, interior of the neuron itself. And that's what the resting membrane potential, the resting potential is itself. Now, upon initiation of this action potential, that initiation of action potential occurs in the axon hillock, so it's all or nothing stimulation that occurs. If, again, the amount of stimulus received from this presynaptic neuron is enough to depolarize this membrane enough, the axon hillock responds, there's initiation of an axon potential, and then that is conducted, an action potential is conducted down this axon to this nerve's then synapse that it makes with another cell, whether that be another neuron or a muscle in a neuromuscular junction. Within this axon itself, this pink coloration of these cells surrounding this neuron axon, those are known as Schwann cells, and their purpose is to facilitate action potential propagation down this axon. So sodium and potassium channels are oftentimes located at the nodes in between these two Schwann cells, and so then depolarization down this axon usually occurs more predominantly in these gaps in between the Schwann cells. And so that type of conduction is called saltatory conduction. Okay, and what that does is, again, enhances the signal propagation down this long axon. You could think of it as being equivalent to a transformer in a long power line, bumping up the signal. Anyways, once that signal reaches the termini of this neuron, this neuron then becomes the presynaptic neuron and releases neurotransmitters into the synaptic cleft and ultimately depolarizes the next neuron, or initiates contraction in the neuromuscular junction. If we take a closer look at the synapse, this is the presynaptic neuron and the postsynaptic neuron. As an action potential is received, there is release of acetylcholine, in this case, into this into this synaptic cleft. And then the postsynaptic neuron has acetylcholine receptors that then acetylcholine binds to, and that begins to initiate depolarization of that postsynaptic neuron. Now, acetylcholine remains in the synaptic cleft. Ultimately, an enzyme called acetylcholinesterase breaks down that acetylcholine into choline and acetic acid, which is ultimately transported back into the presynaptic neuron and then repackaged into acetylcholine and packaged into a vesicle containing an acetylcholine transporter. So these vesicles stay poised until an action potential is received, and then again, there's exocytosis of that neurotransmitter into the synaptic cleft. And so if this again synapses with a muscle, this is called a neuromuscular junction. And also, if this is a neuromuscular junction, then this presynaptic neuron is called an alpha motor neuron. And again, that would define a neuron that junctions with muscle. So that's just a very brief review of the nervous system. Now we're just going to briefly touch on Guillain-Barré syndrome. So Guillain-Barré syndrome is an acute, rapidly progressing inflammatory demyelinating neuropathy. It results in dysfunction of peripheral nerves, causing numbness or weakness. And so if you look at these MRIs, this is a cross-sectional MRI, and then here you see the longitudinal spinal cord depicted here. Within these MRIs, you see regions of increase in sort of radio opaque appearance here and here, here and here. And what that denotes is some sort of inflammation or demyelination of this nerve itself. And so this usually presents with peripheral numbness or weakness, and then ultimately that peripheral numbness or weakness begins to move centrally. So that's how people will present. The pathogenesis of this disease, although is heavily unknown at this time, believe that it goes something like this, that there's some sort of pathogen entry, usually through the gut mucosa or epithelium. Could be a virus. And some people also believe that vaccines will induce Guillain-Barré syndrome, although there's no causative evidence to actually suggest that. Then an immature antigen-presenting cell is inactivated and through lymph node migration matures into an antigen-presenting cell. Mature antigen-presenting cell. This activates an arm of your adaptive immunity. This is immunity that has to be taught that the invader is an invader. And that occurs through this sort of pathway, including a major histocompatibility complex. CD4 T cells are activated, B cells are activated, ultimately antibodies are produced. And this would be an example of an antibody. Consists of two chains. This is heavy chains and then light chains. And in these light chain regions, it's a variable region. And this is the region in which the immune system teaches the antibody how to recognize the invader. Oftentimes what happens is, or in this case, what happens is that the proteins that are produced here, this variable regions, recognize neuronal proteins and then begin to attack the nervous system itself. So this is a pathway called an autoimmune disorder, because your body is generating antibodies that specifically target a component of itself that aren't supposed to be targeted by the immune system. So once those antibodies are created, macrophages, which are also part of the immune system, transport across the vascular wall, and also antibodies transport across the vascular wall and also the blood-nerve barrier. Then those antibodies then bind to proteins in myelin and the nodes of Ramvayir. And when that happens, and also macrophages also begin to attack the Schwann cells themselves, begin to phagocytize them, cause an inflammatory response, and begin to destroy them. When that happens, these antibodies physically cause a loosening association of the Schwann cell, the myelin itself, and that reduces nerve conduction, because remember, these nodes of Ramvayir are important for saltatory conduction and propagation of the action potential. Same thing with macrophages that are then ultimately recruited to that area. And so what happens is that these antibodies binding form what's called a membrane attack complex. And again, that's what this process describes. And so there are several different classifications of Guillain-Barré syndrome. There's an acute inflammatory demyelinating polyneuropathy. It's the most common form. We believe it's caused by an autoimmune response directed against Schwann cells. There's the Miller-Fisher syndrome. It's Guillain-Barré component of a subcategory of Guillain-Barré syndromes. It's rare, accounts for less than 5% of cases. Manifests as descending paralysis, affects the eyes first, ultimately leading to ataxia. And it proceeds in the reverse order of the more common forms. Okay, the more common forms would start with peripheral paralysis and then ascend to central paralysis. The acute motor axonal neuropathy attacks motor nodes of Ramvayir. Disease may be seasonal and recovery can be rapid. Okay, and then there's specific antibodies that are present with this type of Guillain-Barré syndrome. The acute motor sensory axonal neuropathy also affects sensory nerves within nerve axonal damage. Recovery is slow and often incomplete. Acute panatomic neuropathy, it's the most rare variant associated with a high mortality rate because increased risk of dysrhythmias and may cause encephalopathy. Okay, and then the final one is Bickerstaff's brainstem encephalitis that has an acute onset of ophthalmoplegia, ataxia, disturbance of consciousness, hyperflexia, or Babinski's sign usually has a good prognosis. And so with the exception of acute motor sensory axonal neuropathy and acute panatomic neuropathy, Guillain-Barré syndrome is usually completely recoverable. And what I mean by that is that people often recover completely from the syndrome and often go on to live pretty normal and healthy lives. There are only a few rare exceptions to that. The signs and symptoms and diagnosis. Oftentimes it includes bilateral numbness, tingling, and weakness, usually originating in the lower extremities, but again, that depends on the specific type of Guillain-Barré syndrome that the person has. In general, you would look for peripheral numbness or weakness. Weakness that rapidly progresses in an ascending fashion, and that could be from hours to days, depending on the different type of Guillain-Barré syndrome the person has. The arms and facial muscles also become affected. That would include drooling, difficulty swallowing, and maintaining airway patency. The diagnostic criteria is usually an elevated protein level in the cerebral spinal fluid. Electromyography, it'll usually indicate slow conduction or conduction block. Increased white blood cells support differential diagnosis. That means there's some sort of infection that's occurring. The treatment, although there's no cure for Guillain-Barré syndrome, again, most people recover fully. In the hospital, the goal is to support breathing and clearance of secretions. Oftentimes, this will require tracheostomy and mechanical ventilation in about 30% of patients or people that have Guillain-Barré. You want to prevent pneumonia, prevent bed sores, pressure sores. And you want to and those may be due to tracheostomy or inability to take deep breaths, such as the case with pneumonia. The bed sores and the pressure sores often happen because somebody is not turned appropriately and they maintain a lying position for a prolonged period of time. Plasmapheresis has been shown to have some benefit. Also, gamma globulin taken from donors oftentimes blocks epitopes, autoantibodies, and autoantibodies are generated towards the Guillain-Barré antibodies. Physical therapy will be necessary and respiratory augmentation may be required for some time. Paralysis lasts about 2 to 4 weeks. From the onset to full recovery from the onset to full recovery usually takes about 2 to 4 weeks. And then most people regain full functionality. There's about a 3% rate of recurrence. And so somebody has a period of time where they have Guillain-Barré syndrome, the likelihood of developing those symptoms again are very, very minimal. So next we're going to discuss myasthenia gravis. Myasthenia gravis initially usually presents with central weakness, and that would include signs and symptoms that may also be associated with stroke, such as unilateral facial drooping of the eyelids and corner of the mouth. In myasthenia gravis, what happens is that there is depletion of the surface area of acetylcholine receptors. And so the acetylcholine receptors are degraded and are missing, and there's also seems to be remodeling of this muscle itself, resulting in less surface area, such that when there's release of acetylcholine from this presynaptic neuron, and acetylcholine enters the synaptic cleft, the muscle itself is unable to recognize that acetylcholine and initiate contraction because the receptors recognize acetylcholine and acetylcholine receptors are not present. It's thought that circulating antibodies or autoimmune disorders, they may also block acetylcholine receptors, and those antibodies may be passed through the child through the placenta. It could also be that an individual has a genetic defect that results in the reduction of these expression of these acetylcholine receptors. Now, it appears that the thymus gland may be involved in myasthenia gravis. The thymus gland is a lymph gland located under the sternum. It serves a main function during early development, and 3/4 of patients of myasthenia gravis have hypertrophy or tumor in the thymus gland. So there seems to be a very large association between thymus-related hypertrophies and development of myasthenia gravis. The signs and symptoms include breathing difficulty, respiratory muscles may be affected, difficulty chewing and swallowing, difficulty climbing stairs or lifting objects, difficulty talking, drooling or drooping position of the head, changes in voice, facial paralysis, fatigue, weakness of eye muscles. Oftentimes there's fluctuating muscle weakness and fatigue. There's increased weakness during activity and increased recovery time during rest. And oftentimes the muscles that control the eyelids and facial movement, including the mouth, are particularly susceptible. And so a differential diagnosis of those signs and symptoms would be a stroke or cerebral vascular accident. There's classification for this disease. Class 1 would be any eye muscle weakness, no other evidence of muscle weakness. Class 2, eye muscle weakness, limb weakness of other muscles. So that's defined into 2 subclasses. Class 2A is predominantly limb or axial muscles. Class 2B is predominantly bulbar and respiratory muscles. Class 3 involves the eye muscle weakness, moderate and also moderate weakness of other muscles. Again, that could be either limb or axial muscles or bulbar and or respiratory muscles. Class 4 involves eye muscle weakness, severe weakness of other muscles as well. And again, there are several different classes of class 4 Guillain-Barré or myasthenia gravis, and that would include limb or axial muscles, or predominantly bulbar or respiratory muscles can also be included. Class 5, oftentimes intubation is needed to maintain a patent airway. So that would involve the most severe respiratory muscle weaknesses of all the different classes and be the most serious. So the seriousness of the disease becomes worse as somebody progresses through the different classes. The treatment, the acetylcholinesterase inhibitors, those might be effective initially, but oftentimes they lose their effectiveness. Thymectomy, plasmapheresis, or immunoglobulin therapy. Adrenocorticoids, oftentimes they have some side effects associated with them, prednisone, cyclosporin A. And also you want to prevent pneumonia, prevent bed sores, prevent infections, and initiate incentive spirometry. And this is not a progressive disease, so symptoms might fluctuate throughout the individual's life. Might be a period of times where they have very severe disease or appear to have very severe disease, and then there might be periods of time in their life where they're relatively asymptomatic. Comorbidities. Comorbidities accompanying prolonged ventilation or nursing care include cubitus ulcer, sepsis, pneumonia, and then we'll cover pneumonia in a different lecture in a little bit more detail. Thank you for your time.